Hi, good morning. Uh, Today class is about trauma, how we deal with that in the emergency department. So, trauma. ஸோ ஃபஸ்ட்டு ஒரு கேஸ் எப்படி வரும் நம்மக்கிட்ட அப்படின்னு பார்த்தோன்னா, எய்தர் வித் ஹிஸ்ட்ரி ஆஃப் ஏதாவது டூ வீலர் வர்சஸ் டூ வீலர், இல்லைன்னா ஃபோர் வீலர் வர்சஸ் ஃபோர் வீலர், காமன்லி கால்ட் அஸ் மோட்டர் வெஹிக்கல் ஆக்சிடென்ட்ஸ், இல்லைன்னா ஹைட்லேருந்து கீழே விழுந்துட்டாங்க, ஃபால் ஃப்ரம் ஹைட், இல்லைன்னா அசால்ட், இல்லைனா ட்ரெயின் டிராஃபிக் ஆக்சிடென்ட்ஸ். இந்த மாதிரி இருந்து வேரியஸ் கைண்ட் ஆஃப் ட்ராமாவிலேருந்து வர்றதுலாம் how will they present and how will we manage it in the emergency department. That is what we are going to see today. So yeah, so ஒருத்தர் ஃபஸ்ட்டு ஒரு ஆர்டி ஆகிட்டு வராங்க. இட்ஸ் எமர்ஜென்சி டிபார்ட்மெண்ட். what we have to நம்ம எது ஃபஸ்ட்டு நம்ம கான்சன்ட்ரேட் பண்ணோம், ஆம்புலன்ஸ் சர்வீஸ், தட் இஸ் இஎம்எஸ். அந்த ஆக்சிடெண்ட் ஆன ஸ்பாட்லேருந்து தே ஷுட் கால் அஸ், லைக் இந்த மாதிரி ஆர்டிஐ இருக்குது, பேஷண்ட் இந்த கண்டிஷனில் இருக்காங்க. வாட் தே வில் டெல் அப்படின்னா, ஃபஸ்ட் வைட்டல்ஸ். வாட் வில் பி இன் தட் வைட்டல்ஸ்? பிபி, பல்ஸு, SpO2. These three things they will tell, and one more thing they will tell is AVPU scale. AVPU na patient, are they alert? Are they alert only to verbal response? They are only responding to painful response, or unconscious. This is good, this is bad. So yeah, so in the informations we get from EMS, right? From that, what we can do is, as a ED, we have to start the management at the spot with the help of EMS. We tell them if the patient is unconscious, we assume that cervical spine injury will be there. So we put C collar and keep the cervical கழுத்தை நகர்த்தாமல் பார்த்துக்கணும். சரிங்களா? இது ஃபஸ்ட் we tell them that. And if the EMS is equipped well to intubate, tell them to intubate that case and start ventilation with the ambu bag and bring the case. So, and if there is any hemorrhage bleeding from limbs or abdomen or hand or anywhere, try to compress it with compressive dressing and bring it here. Or if it is like major limb fracture, you can apply tourniquet. ஏதாவது அந்த ரத்தம் கீழே லீக் ஆகாமல், அதிகமாக போகாமல், வேஸ்ட் ஆகாமல் இருக்க, அதுக்கு மேலே எங்கே அடிபட்டுருக்கோ அதுக்கு மேலே லெவலில் லைட்டாக கட்டி போட்டு வர சொல்லணும். ஸோ திஸ் வாட் வி வில் டெல் டு த EMS. ஸோ EMS as emergency medicine, from the incident, EMS brings the case with the ambulance to the hospital. What we do here, we have emergency department. In that, red zone would be there, yellow zone would be there. First thing we will do is triage start from the incident spot only. So the patient unconscious இருக்காங்க, we take it to the red zone. So from the red zone, what we will do, this is where fission comes to play அதிகமாக. So first patient receive on only, we assess for primary survey. then secondary survey. In primary survey, A, B, C, D, E. இது எப்படி பார்த்தோம்னா, we assess these five things, and simultaneously we do some intervention to if there are any abnormality present. Okay, yes. So we'll go on deep to it. Okay, from EM physician cases here. So first, primary survey. Primary survey, what we assess first is, according to the new ATS guideline 2026, it is X, which means compression, which we have started in the spot of the incident spot, right? So compress the exaggerating bleeding, so we prevent the loss, to prevent hypovolemic shock. This is the first thing we do, either by tourniquet or applying a tight dressing with sterile gauzes, with gauzes. So we do this first. Then airway. In airway, what are the things we have to manage is, we see if the airway is patent or not. With the patent means we're checking for an airway. We ask the patient to speak. If they speak, the airway is patent, no need to intubate right away. If the patient is not speaking in this RTA or any kind of traumatic trauma, very high level velocity injury, and missing, pooling of blood, snoring sound, pooling of any kind of secretions, is all that present, we go for intubation in this airway. So we make the airway patent by intubating. How we intubate? In RTA, in trauma, mostly we prefer video laryngoscope to prevent cervical spine movements, so that if there is an injury to the cervical vertebrae, which will be minimized. That's why we prefer video laryngoscope in this kinds of cases. And now, but traditionally what we use is laryngoscope only. With that we intubate. So we secure the airway, right? So after that, we will move on to breathing. Yes, breathing, same thing. If we can take care of the airway patency by mechanical ventilation, breathing would be managed partially. So in this, additional thing what we will say is respiratory rate, saturation, bilateral air entry, if there are any added sounds. So respiratory rate could be high, could be low, could be dyspneic, difficulty in breathing would be there, any kind of respiratory discomfort would be there, rate would be increased. In injury or any other trauma cases, the respiratory rate would go down as the urination progresses. So this may vary. Saturation may be normal even in unconscious patients, may be decreased. If it is decreased, what we have to think is some kind of injury to the chest is there. Then air entry, we have to check for bilateral air entry, both sides equally present, be present means both side equally present. This is good. If it is not, which side is decreased, we have to see. And added sounds, which side sounds are decreased, we have to see. The pneumothorax, these two things we mostly see in trauma. So yes, if any of this presents in this place where we use ultrasound to see lung sliding by B mode and seashore sign using the B mode and the lung sliding. These two things we will see. If lung sliding is absent and the seashore sign is absent, barcode sign is there, we will think it's mostly pneumothorax. And if there is just a pneumothorax, we have to check whether it is simple or tension. By that what we mean is BP is low, rectal shift is there, patient is in shock, saturation might be normal. Saturation means saturated SpO2 99 would be there, maybe, yeah. The main reason about the tension pneumothorax is that it is the IVC get compressed, venous return decreases. That is why the pathophysiologist, so we relieve the tension by ICD. So this is what we do in breathing. So and now the thing, circulation. Here the most important things where we do stuff like MTP activation. It will happen before only. If we suspect the patient is in shock, EMS சொல்றாங்க அப்படின்னா, we'll arrange O negative blood before the patient arrives and we'll start the blood immediately. So in circulation part we take care of BP to maintain the map, to give brain enough perfusion. That is the idea. So in circulation we check BP, check CRT. These two things we will check, and we put large IV line cannulas and send for samples to see for any other coexisting abnormalities. In the elderly patient, they may be diabetic, they might have hypertension, and a lot of comorbidities are there. So we will check for that also. So and ABG we will send here for see if any coagulopathy, not coagulopathies. ABG we see any acidosis there. Hypovolemia will cause lactate to increase in the blood, which will lead to lactic acidosis, which is metabolic acidosis, which we don't want in the trauma patients. And here we will start. We give 1 liter of oral. The patient on receiving BP is 90, 60 or below than that. If patient respond to 1 liter of fluids after giving it, repeat BP 160 or 110/60, patient is responding to the fluid, so it is good sign. If they are not responding and we give blood, even to the blood they are not responding to it, it is a very dangerous condition. In subsequent lectures we will see what we will do for the patients also. So circulation part, this is the basics. So yeah, and now we come to disability. This is the place where we check GCS and EVM and CBG. This also will check here. According to the new guidelines, what they are saying is don't assess GCS before resuscitation, as they say, by some new way of thinking is that patient is in shock, or if the patient is diabetic, if they get into an RTA or any kind of trauma, they might present in DKA. Also, there might be a chance if the patient has CKD, they might be in pulmonary edema. That's why their GCS is very low. So what they are telling is correct the patient's underlying cause, rule out the underlying cause. That is, by that what they mean is it's not purely due to the trauma, hypovolemia, or any kind of injury related to trauma. So GCS you don't assess at first. That's what they tell you. But we put it anyway. So GCS we put at that time what we will think, what we see in the patient. The patient is unconscious, not responding to any kind of painful stimulus. We put GCS is lowest GCS 3. With this only we can get into the idea whether we intubate or not. With this also, so GCS of less than 8, and by that what I mean is 3 to 8 is the indication for intubation. So disability part is that, and here we also can check for any focal neurological deficits, where would be the anything, any deficit would be there, like if in head injury patient is moving on 4 limbs, if the patient is semi-conscious, like moving, fuel to painful signals, or partially responding to oral commands. So that is that about disability. So last thing today classes is exposure. In exposure, in trauma, we don't know where the injury would be exactly. Patient might be wearing some tight clothes or very big thick clothes to get teared. Patient might have blunt injury, so we cut off all the clothes and we look at the patient top to bottom completely, do the physical examination where all the injuries, check, rule out any other injuries, and send for appropriate investigations accordingly. So today class is about this. This is our first starting class. Hope you all will enjoy this. So in future what will go on in better, I mean today is the first class, and starting in a very ஒரு டைம் டேபிளே இல்லாமல், ஒரு ப்ரிப்பேர்ட்னஸே இல்லாமல் ஒரு கிளாஸ் ஆரம்பிச்சிடும். பிகாஸ் ஐ ஹவ் ஸ்டார்டட். That is how we get motivated. We don't wait for a good moment to start. We start it and we rectify our mistakes on the way. So that is my plan. So in subsequent lectures, I will upload at least 1 lecture per week. I will try to upload 2 lectures, but at least one class per week I will try. So I will upload that. And next class என்ன பார்த்தீங்கன்னா trauma in different age groups, which means pediatrics, old, not old, elderly, and pregnant women. This is the topic of our next class. If you people have any doubts, you can ask in the comment section. And இது class வந்து ஆர்கனைஸ்டாக இல்லைன்னு நினைக்கிறேன். ஃபஸ்ட் கிளாஸ் it will get improved. And if anybody is having the reference doubt, most of my content will be from Tintinelli 9th edition, which is emergency medicine book. I am an emergency medicine resident. So yeah, I'm here to share my knowledge and study also. Also train myself to teaching. நான் கற்றுக்க வந்துருக்கேன். நான் கற்றுக்கிறத சொல்லி கொடுத்து அதை எப்படி பழகுதுன்னு கற்றுக்கிறதுக்கு தான் I started this activity. So thank you. I'll see you on the next class.